Our last slideshow presentation for the year. So we're going to talk about school-based physical therapy. So we're going to focus on the laws and regulations that are leading up to the services that are in place for school physical therapy and um, what's completed and what's entailed for school therapy. So to start it off, we'll look at the ICF model with the health condition, the environmental factors, the personal factors, everything that plays a part into the body function and structure, or the impairments, the activity limitations, and participation restrictions. So in terms of school physical therapy, a lot of the times what we're looking at is the participation restrictions. So can they maneuver throughout school as independent as possible? Can they interact with peers? Can they play at the playground, get on and off transportation? So we're looking more at the participation level, but we're also addressing the impairments and limitations that are holding them back, and those are the things that we're going to work on. But our main focus will be on participation in the school environment. So let's take a look at the timeline of federal laws and civil rights and acts that enabled us to have such good services during the school environment. So we're looking back towards the 1970s. This is when things started. So this is when we were looking at the Rehab Act, which is the Section 504. So some of you might have heard of 504 plans. Um, this is where we're really prohibiting discrimination. So we're allowing reasonable accommodations for people with disabilities. So that is what the Rehab Act entailed. And this is very generally speaking. We'll get into that in further details. Moving forward from the Rehab Act, we have the Americans with Disabilities Act. So I'm only talking about the bottom two green bullets at this point. So the Rehab Act was in the 1970s. The American with Disabilities Act was in the 1990s. So we saw a change with the legislation with those two. And again, we'll look into that further in further detail. We also, on the top, we see it begin in the 1970s with the Education for All Handicapped Children Act, the EHA, that started in the 1970s. So what we know around this time is that prior to the 1970s, students with disabilities had little to no education. They were not the same. They were not treated the same. They didn't have opportunities similar to typical peers. So kids were not expected to go to school. They didn't have to go to school. They didn't have services in place to really allow them to go to school. So in 1972, only about a half of kids with disabilities were getting an education of any kind. So students were exempt from attendance. They were not required to go. So everything started to change in the 1970s with the EHA, the Education for All Handicapped Children Act. This was the first time that there was free and appropriate education for kids with disabilities. And this was also the first time that kids with disabilities were encouraged to have the least restrictive environment. And that was actually written into law that they were to be placed in the least restrictive environment. So it wasn't the best situation for kids with special needs to all be placed together in a separate room away from typical peers. This is where we really encouraged them to be a part of things with typically developing peers. So we're going to go through this timeline and look at things in further detail. So first thing we'll look at is the Section 504 of the Rehabilitation Act. So this is the first thing on the bottom of that timeline. You do not need to know timelines. You just need to know the general ideas behind the different acts. So Section 504 of the Rehab Act is an important one to know. This was the first civil rights protection for people with disabilities. So if you notice on the timeline, at first was the Section 504, then in the 1990s came the ADA. So the Section 504 was really the first push towards the creation of the ADA, which is the Americans with Disability Act in the 1990s. So what Section 504 of the Rehab Act instilled is that any institution receiving federal funds were required to comply with Section 504. And this stated that you have to be able to give access and participation for people with disabilities. So anybody receiving federal funds had to comply with that Section 504. So this was schools, colleges, and universities. So places that don't receive federal funds would be privately funded. So religious-based schools that are not federally funded do not have to comply with this federal rights protection. So we'll talk about the idea, and we'll also talk about the 504, and we will compare them later on. But the Individuals with Disability Education Act is called the IDEA, and it's a little bit more strict with who falls under that category than with the Section 504. The Section 504 is a little bit more general, and if you don't fall under the IDEA, you might still fall under this Section 504. We'll talk about that further. The 504 doesn't only include when you're at school or at college or at your university, it also includes access to extracurricular activities. So allowing kids with some kind of disability to play sports, to have after school care, so allowing accommodations to allow these children to participate in these activities as well. So again, this Section 504, it led the way for the Americans with Disability Act, the ADA, which was in the 1990s. So this was a civil rights law that prohibited discrimination against individuals with disability in all areas of public life. So this was no longer just schooling, you're including jobs, transportation, public and private places. So this is where, you have your ramps, you have your wider doorways, you have wheelchair accessible bathrooms. So all of this started with the Americans with Disability Act in the 1990s. It also helps to prevent discrimination by employers for firing and hiring of individuals with disability. So what it requires is that an employer has to be able to provide reasonable accommodations to employees with disabilities. So you cannot just not hire them or you cannot fire them. You have to provide reasonable accommodations. So overall, what Section 504 and what the ADA provides is accommodations. So it's not providing services for people with disabilities, it's allowing them to participate by providing accommodations that allows them access and that allows them usability of different features. So some examples of general accommodations would be environmental strategies, organizational strategies, behavioral strategies, presentation strategies, evaluation methods. So a lot of times, like if you're thinking of maybe someone you've known on a 504 plan, maybe they have extended test taking time. Sometimes kids will get placed on 504 plans when they have ADHD and they need a little bit more organizational help, a little bit more the teachers checking in on their assignment journals, and it's just some accommodations. It's not any extra services, but they'll put things in place to really help students who need these little accommodations to be successful with their schooling. And again, the ADA is looking at more public and private employment, transportation, and everything like that. So just as a refresher of the timeline again, we looked at the Rehab Act and we looked at the Americans with Disabilities. Now we are going to jump back to the 1970s and look at the top row with the Education for All Handicapped Children Act, the EHA. So the Education of All Handicapped Children Act began in 1975, and it was an evolving act over many, many years. And what it stated in the initiation of this program was that children aged 6 to 21 were entitled to free and appropriate education. That's what the FAPE stands for, free and appropriate education. That included related services. So here's where you don't just get into accommodations, you get into services that are going to help with these free and appropriate education. So kids that had disabilities, no matter what level their disability is, were required to be able to go to school and get a free and appropriate education and would be allowed to have the services needed to have that appropriate education. So within that related services term is physical therapy. So any service that's going to allow you to have that appropriate education is a related service, and physical therapy for certain kids is a related service to getting their appropriate education. So because this is a public law, there are federal funds that help the states to educate disabled students. So this Education of All Handicapped Children Act put funding to help with all of this. So fast forward 11 years further, and they reauthorized the Education of All Handicapped Children's Act, and they put a provision in it. So what we saw before was that this was for children aged 6 to 21. So you're thinking elementary, middle, junior, high school. All throughout that schooling, you fall under the Education of All Handicapped Children's Act. Well, in 1986, they realized, wait, we're missing a group here. What about the preschool kids? So I'm mistaken with my word. It's not the preschool kids that they were concerned about in 1986. It is the early intervention, which is birth to 3 years. So they were concerned about the early intervention services of kids that were not in school yet. So birth to 3 years. So that's what was instituted and included in this provision of the Education of Handicapped Children Act in 1986. So with this provision, what does all of this entail? What encompasses this Education of All Handicapped Children Act? Well, there's 7 items that are included in this act. 0 rejection. All children, regardless of the severity of their condition, are able to go to have a free public education because of this act. 0 rejection. This was big because the higher severity, the lower the chances of that child getting to school before this act. Number 2 is the least restrictive environment. So children with disabilities are educated with children without disabilities as much as possible. So not only are they coming to school, but they're not sitting together in their own room, sheltered from typically developing peers. They're together with them. They're in the least restrictive environment. So as long as they can excel and as long as they can thrive in the typical classroom, that's where they'll be. And if they can't be there, then it will be the least restrictive environment. Number 3, the right to due process. So parents have the right to be part of this whole process. And if they don't think something's going right, they can be represented by counsel. They can have transcripts of every meeting. They can fight for the rights of their child. Number 4 goes along with it, the parent participation. Parents are heavily involved. Once this act was initiated, they realized that this is a huge role. The parents need to have a say in what's going on in the school and be participating in the goals and everything going on with their education. So the parents were involved after this. The non-discriminatory evaluation. So you're really assessing them for what they can do, what they can't do, and how you're going to get them to grow. You're not discriminating based on anything else. The individualized education plan is number 6. So it's shortened for the IEP. So this is what you hear physical therapists talk about in the school environment. They are on an IEP plan. So this individualized education plan is the foundation of service delivery in schools. This is how you make your goals. This is how you set your plans for the year. This is how you determine what needs a child is able to use as their related services to be able to be successful in their school environment. And number 7, to get into their related services, it's assisting the children in meeting their educational needs. So things that can be part of their related services: PT, OT, speech, transportation, audiology, psychology, recreation, medical services, but the medical services are for diagnostic or evaluation purposes only. So you don't see that near as much because it's usually a one and done for a diagnosis or an evaluation. So usually the other ones are ones that you'll see more on an ongoing basis. So again, they have to be related to assisting the child in meeting the educational needs. So this is where outpatient physical therapy and school PT is very different. Outpatient physical therapy, as long as the child has some kind of functional limitation or some kind of impairment or some kind of participation restriction, we can treat them. If it's something that physical therapy can address and improve, then they're appropriate for outpatient PT. In the school, it's not the case. They might have some functional limitations. They might have some impairments, some gross motor delays, um, some asymmetrical gait, things like that that we would treat in an outpatient setting, but that won't get addressed at school. It's not going to assist in meeting the educational needs. It has to be related to their schooling, their transportation, their use of the playground, their getting between classes, managing their school supplies, doing their schoolwork, interacting with their peers. It has to be related to their educational needs in the school to be an appropriate related service for them. So again, in 1986, this was where early intervention was initiated, which is birth to 3. So there were a couple extra pieces of information that are really specific to birth to 3 and important to what this provision was all about. So you're really enhancing the development of infant and toddlers with disabilities and minimizing developmental delay. So they were starting to realize that if they put services in at a younger age, they're minimizing the developmental delay as they get older. So they're seeing the benefit of working with these kids and getting them referred to services early. We know that's a great benefit as well. So the purpose is to enhance development. So the purpose here isn't anything for school related. They're not in school, right? They're at home or they're at daycare. They're not in a school environment yet. So it's just to enhance the development. So things are a little bit easier here to get services. What we're looking at is we want the services to occur in a natural environment. We know that infants and families learn best through their everyday experiences and their interactions with familiar people in familiar contexts. So we want to come to the family, come to their home, go to their daycare, work in their natural settings where they are going to be every day, and it's easy to replicate activities, it's easy to use their own equipment. We're getting into their natural environments. So with early intervention services, that's what you see. It's for kids birth to 3 years of age, and they're coming into your home. It is very family centered, just like an IEP. For the school age kids, families are a huge part of the early intervention process, and you'll see early intervention abbreviated EI. So when I talked about the school age kids, and the plan that's created is the Individualized Education Plan, the IEP. For early intervention, it isn't called that. It's called an Individualized Family Service Plan, an IFSP. So those are important differences to know. Which one's for the school age, the IEP, which one's for the early intervention, the IFSP, which makes sense. Birth to 3 years of age, it's really a family approach, right? The child isn't off on their own at school. It's not an individualized education, it's individualized family plan because the family is really what you need to prioritize and to really promote their growth. So usually you have a primary service provider, and that's usually a case manager or the professional that's most relevant to the child and family's needs. So if it's a child that really mainly is just delayed with speech, maybe it's a speech therapist. If it's a child that really just has some gross motor delays, maybe it's the PT. If they have a lot of services, usually it'll be the case manager. That's the primary service provider. And because this is only a birth to 3 plan, there has to be a transition. It can't just be, okay, you're at 3 years old, you're aging out of this program, sorry about your luck. So there's a transition plan, and it provides the transition to a local preschool at an age 3 where their services can start there. So you're going to help with that transition and not just say, sorry, see you later. Makes sense. So there are tri-state early intervention services. They're usually through the county that you live in. They're called something different depending on which state you live in. So in Ohio, for early intervention services, you'll hear them called Help Me Grow. So you refer someone to Help Me Grow services to get them engaged with early intervention, birth to 3 years old. If they're in Kentucky, the same program is called First Steps. If you're in Indiana, the same program is called First Steps as well. So just different names for that early intervention services. All right, so the EHA was changed and formed into the IDEA, the individual, excuse me, hold on. So the IDEA was created from the EHA for the individualized Individuals with Disabilities Education Act. So it's really the same thing. It just was given a new name and kind of revamped around 1990. And an extra letter was added at one point as well in 2004. So in 1990 is when the IDEA Act included preschool children. So we had talked about including that early intervention of birth to 3, and now we're discussing that preschool 3 to 5. So this all started as well. So the goal for all of this, for the All the IDEA Act, so this is birth to 21 throughout the whole act, is to meet the unique needs of children with disabilities and prepare them for further education, employment, and independent living. So birth to age 3, that is the IDEA Part C. So you see this on the very bottom of your slide here. I'm going to switch it. So IDEA Part C is birth to 3 years. IDEA Part B is the 3 to 21 years. You don't really need to know this. I'm not going to ask you about this, but you would need to know that early intervention is the 0 to 3. Then there's the preschool of 3 to 5, and then there's the school age of 6 to 21. So just knowing those differentiations. So when you're looking at early intervention, you're looking at a child with a disability in any area, very generally speaking. If they have a social delay, if they have a communication delay, if they have a gross motor delay, if they have a fine motor delay, if they have a nutrition concern, any part of their development is falling behind, they would qualify for early intervention. Once you move into more of the preschool and school, it gets a little bit more tricky in who qualifies. And we'll talk about who qualifies later. But they have to be qualified as having a disability in a different way than they were with early intervention. Once they get towards the end of their schooling, we're helping with that transition for either further education or for employment and for independent living, trying to get out of your family home and have your own living situation. So you have transitional services through the IDEA that helps plan for the transition from early intervention to school and from school to independent living, employment, or further education. So let's take a look at comparing the Section 504 in the IDEA. So just to kind of recap on the Section 504, this provides rights to students for issues in the school and outside of the school. So it can include extracurricular activities, sports, and after school care as well. The purpose of that 504 is that it can accommodate and provide accommodations so that a student with a disability has equal access to the general education curriculum. So some of these accommodations might be audiobooks, note-taking aids, extended time to complete tests. I've seen ones where it's extended time between classes or leaving your class at a different time. So any kind of accommodation that provides access and opportunity. This, again, as a little summary, was the first federal civil rights protection for people with disabilities. And it paved the way for the Americans with Disabilities Act that was expanded outside of just the school environment. So when we look at comparing that Section 504 with the IDEA, I've said this a couple times, but we haven't gotten into the very specific definition of disability. But Section 504 has a very broad definition of disability. So you just need to have something that impacts a major life skill to be classified as having a broad definition of disability. The specific definition of disability we'll talk about further, but there's a big difference between who would qualify for a 504 because of the broad definition versus the IDEA because it's a very specific definition under the IDEA. You have a civil law versus educational law. So you see the IDEA, which is in the school environment and early intervention, or the civil law, which is in public and private sectors. The Section 504 is not age specific, whereas the IDEA is school aged and early intervention, so 0 to 21 years. On a Section 504, you have a 504 plan, and that's where it states out all your accommodations. On the IDEA, you have the IFSP, which is the Individualized Family Service Plan for the early intervention, or the IEP, the Individualized Education Plan for the school-age child. That refers to what kind of services that will be provided to allow you free and appropriate public education. The other thing to know is that you can receive accommodations and services from one or from both of these. So you're not limited. It's not a one or the other kind of thing. You can have services from both. Okay, so back to eligibility for the IDEA. So again, we're looking at 0 to 21. When we're looking at 0 to 3 years old, that's the early intervention services. We're looking at an infant or a toddler with a disability, and this is more general as well. So if this infant or toddler is experiencing a developmental delay in at least one area, cognitive, physical, communication, social, emotional. So this sounds to me like ages and stages. Is that kind of ringing a bell with you? You know how you did the ages and stages questionnaire and it went through all of these developmental domains. So this isn't the only way that a child can qualify for early intervention, but it's one way that it can. If you do an ages and stages questionnaire and they're falling behind in one of those areas, that's a standardized assessment. So that is something that could determine your eligibility for early intervention services if you're falling behind. And again, this is free services. So it's something that you should encourage people to take advantage of. And it's also something that the services will come into your natural environment. So you don't have to go out to an outpatient clinic to get these services. They come to you. And it's free. It's great. So if you can have a delay in one specific area like we just talked about, or you can be diagnosed with a physical or mental condition that has a high probability of resulting in developmental delay. So as long as you're diagnosed with that condition that has a high probability, you can also be eligible for early intervention services. So again, that ends at 3 years old. They have that transition plan where they'll help you get set up with a preschool at 3. So preschool age is usually about 3 to 5 years old. And when you transition to that, you have to qualify for the school-based services. So in order to qualify for school-based services, which is preschool to 21, so about 3 years age, 21 years of age, you have to have a disability per the IDEA, which again, if you remember that chart, the specific definition of disability, it's very specific. We'll talk about it. You have to have a disability per the IDEA regulations. So we're switching from very general with early intervention to something very specific with school-based. So here's the federal definitions of disability, and this is what you have to have in order to qualify for school-based services. You have to have a disability consistent with these categories. You have to have autism, or deaf blindness, or deafness, or developmental delay. So the developmental delay is typically where you'll see you need to be 2 standard deviations below the norm. An emotional disturbance, hearing impairment, mental retardation, multiple disabilities, orthopedic impairments. So if you have Down syndrome, cerebral palsy, Duchenne's muscular dystrophy, Those are the kind of orthopedic impairments you'd be looking for, not like a broken ankle. Other health impairments, speech and language, traumatic brain injury, visual impairment, including blindness. So you have to have one of these. You have to fit into one of these categories to receive services. So what happens when you do receive services? So when it's school-based, that's when you create an IEP, that individualized education plan. So you have an IEP team. Who's on that IEP team? Your parents, because we know parents are helping to direct this care. Parents are very involved in helping to create goals. Your regular teacher, your special education teacher, a school district representative, an individual who can interpret the evaluation results, and a child if they're at least 18 or 16 years of age. You can also have an advocate for the family be present as well. So this is typically the team. You typically sit down every so often to look at the goals, to talk about how the child's progressing. So let's look more specifically at the individualized education plan, the IEP. What's included in this? This is not just what physical therapists do. This is the whole school will put together an IEP for the child that it's applicable for. So on the IEP, you're going to state the child's present levels of academic and functional performance. So you can see there where the PTs would come into play at looking at the functional performance, but also many other disciplines are putting together their information. You're going to have measurable annual goals. So the goals are a year in total. You're wanting to meet them by the end of that year. They are academic and they're functional. Again, that's where the PTs come in. Description of how progress towards the goals will be measured and when progress reports will be provided. So it's all written out. Statements of special education and related services. So this is where you are digging into, here are our goals. What services are needed to get her there, or to get him there? So what kind of aids, what kind of services, what kind of program modifications and supports will the child need? So then we are also paying attention when the child is getting older in high school, getting closer to aging out of this program, you're looking at the transitions to the post-secondary goals. So are you going to do some kind of training for the workplace? Are you going to look into furthering your education? Are you looking for independent living skills? So what is your goal outside of high school and how are you going to help get that transition done? One thing about the documentation that's really different from anything else that we've learned about in PT school is that the documentation for the IEP is not medical at all. It's something that is completely understood by parents. So you try to stay away from medical jargon and you keep it very simple, simply worded. So again, this is not just the PT plan of care. This is the whole academic and functional performance coming together. So all those people in the IEP plan and the IEP team are all coming together to write this up. So now we're going to be looking at the individualized family service plan. Do you remember what that's written for? Hopefully, because I'm trying to drill it into your head, that's for the early intervention. What's early intervention? Birth to 3 years old. So what is involved in the IFSP? You're looking at the child's level of development across all domains, including vision, hearing, general health. You're discussing the family and the children's strengths. You're also discussing their needs and their resources. What do you need to support them with? What do you need to find resources for them? Where are the services provided? In a natural environment. The plan, the IFSP is reviewed every 6 months, or if the situation warrants it at a different time, or if the family requests it at a different time. Year-round services are required, so you don't stop and start, you continue to provide services. And again, you're avoiding the medical jargon. It's written geared towards parents' understanding. So what kind of services are provided in early intervention? Usually, again, have that primary service coordinator, which can be from one discipline or it can be like a general case manager. And then any of the services and any of the areas that they have delays in are what you're going to receive services in. It could be all of those. It could be one, whatever you're finding impairments and limitations in. So digging into PT a little bit, what does PT look like for all these? So your PT documentation is somewhat going to be put into those IFSPs and the IEPs. You also have progress summaries, and these are all due at regular intervals or once a year, once every 6 months. You're going to have goals related to function, so those will be what PT is working on. In addition, just like a normal environment with PT, you're going to need to complete your normal PT evaluation as well as daily notes when you're providing any interventions and documenting their progress towards the goals. So it's a little bit double duty. You're going to be needing to be documenting on their IFSP or their IEP as well as doing your PT documentation. So just like every other area of PT practice, you're going to be looking at body function, body structure impairments, activity limitations, participation restrictions. You're going to be looking at all of that for your evaluations, no matter which setting, whether you're in the natural environment with early intervention or whether you're in the school environment. Oftentimes, you'll see a lot of standardized testing in this area. So ages and stages is a good screening for all those developmental areas. We also have the Bailey scales of infant development, the Peabody. You guys should be very familiar with that. The Brunick-Oswestry is what you typically use after you age out of the Peabody. These are used to document the amount and the area of developmental delay. So that's where we'll get how many standard deviations are they away from the norm. What's their Z-scores? What is their age equivalent? So we're using all this to help us determine which areas they need the most services. So we'll be doing those as well. The other standardized test that I believe was mentioned just briefly was the school function assessment. So this is in the school setting, something that you'll see often done because it's looking more at participation restrictions and activity limitations in the school environment specifically. So it's a really good one to use as a physical therapist in the school environment. So what do you really need to know about these tests and measures? Not a whole lot other than you're going to be doing tests and measures in the school environment in the early intervention as well. So you're going to be doing the same measures. The only extra one really is a school function assessment where you're looking at more of the school participation restrictions. All right, so part C, we are talking about that early intervention, 0 to 3 years of age. So when you're addressing PT, you're working on improving strength, improving gross motor skills, mobility, and obtaining any kind of equipment that they might need to help promote these areas as well. So when you're thinking of 0 to 3, you're going to be looking at floor mobility, transitions, standing, walking, jumping, running. All these skills occur through that time frame. So those could be things you're looking at, depending on the level of the child you're working with. Obtaining durable medical equipment. So if this child is a GMFCS level 4, if they have spina bifida, maybe you're looking at standers, you're looking at wheelchairs, you're looking at gait trainers. So looking at getting that durable medical equipment at an appropriate age for them. Orthotics, again, if they have cerebral palsy and you're finding in spasticity, or they're starting to weight bear and they need HKFOs and they have spina bifida, or you have a child with Down syndrome who needs those SMOs, so you're getting them orthotics as appropriate at this age. You're also consulting with other team members, with the family. You're discussing what positions these children need to be in, how are they going to handle them to improve their gross motor outcomes. So same thing you would do in any other setting. PT is going to instruct a primary service provider in improving gross motor skills. So what this means is, again, I talked about you have a primary service provider, and a lot of times it's a case manager. That person often will see the patient more frequently than what you can do. but you want them to be promoting their PT skills as well. So you're going to instruct the primary service provider in how to work on the gross motor skills. So yes, when you go, you're going to instruct the family members, but also the primary service provider is going to go more often. So you're also going to instruct them on how to promote gross motor skills as well during their sessions. So typically with this plan, it is written for a number of visits per month. So usually you will see once a week or 4 visits a month, 6 visits a month, 8 visits a month kind of thing. And they need to meet that. Part B, this is the school environment. So you're looking at access, mobility, safety, and participation in the school environment. So your interventions are going to be related to those items. So a lot of times what ends up happening in the school environment is that PT is more of a consultant. So it's more of a consultative basis. When the teachers and the aides need help regarding the child's condition, how do we get them upstanding? How do we help them use the bathroom when they need to go? How do we help them get from class to class? So we might not be changing things, but we might be getting appropriate positioning of mobility equipment. And then we're going to teach the teachers and the aides how to use that equipment and how to implement it during the day safely and appropriately for that patient. And that's our role. And once that's completed, we might just be checking in to make sure that plan is still appropriate for them and that the teachers and the aides can still follow through with it. We're also looking at safety in terms of transportation, so talking with the bus driver and how to safely get them on and off, how to properly use the tie downs to keep the wheelchairs on the buses. So that kind of education can be involved with our PT. And for school-based PT, interventions plan for a number of minutes per month. So you might hear a child has 120 minutes per month. It's usually pretty low. Because again, a lot of time PT is used as the consultant. Just check in when there's problems, make sure they have the equipment they need, and things like that. So let's look at some PT interventions in the schools. So we are looking at the child's functioning in the schools. So we would look at some of the following activities. It's not limited to this, but just to give you an idea of the kind of things you can address in school. And I've talked about a couple throughout this, but maybe they're having trouble with sitting balance in the classroom chair. Or maybe they're younger and they do circle time on the ground and they have trouble with their sitting balance during circle time. Or maybe it's sitting balance in the cafeteria or even on the school bus or even while swinging on the playground. So things like that, as long as, now it can't just be a child that has trouble with this. If you remember back to the definition, the specific definition, regarding the idea for the school age, it's very specific. So they have to fall into one of those categories for a disability. And then you can work on something like this with them. But not anyone that has trouble swinging on the playground can get PT services. They have to fall within that disability criteria. Maybe it's accessing the school environment. So maybe it's getting into the classrooms, maneuvering the hallways, doing stairs or navigating the elevators, getting on and off the school bus steps, getting into and out of the bathroom, in the cafeteria, maneuvering their trays and their food, participating in gym class, um, maneuvering on the playground, getting to school field trip destinations safely. So you can look at access from those kind of perspectives. You can also look more specifically at playground equipment. This is often a big one. So maybe for kids with Down syndrome or cerebral palsy, where they have more body structure and body function impairments and more activity limitations that are preventing them from using typical equipment. You're looking at how are you going to get them to ride a tricycle or a bicycle on the playground like the other kids? How are you going to get them to maneuver on a balance beam so they can participate? Jumping, skipping, throwing, catching a ball, and other activities that you would see typical peers working at during recess or during gym class. Those are things you could work on. But again, it can't just be a kid that has a difficulty with an area. They have to first be categorized in one of the specific disability categorizations. So what you will typically see with the IFSP, again, that's early intervention, or the IEP, which is the school aged, is that you'll have a long-term goal and you'll have short-term goals. The long-term goals will be titled goal, and the short-term goals will be titled objective. So you'll have a bunch of objectives all related to a long-term goal. So you want to meet those objectives in order to meet that long-term goal. So for the IFSP, we're looking at demonstrating independent mobility. So again, we're talking about 0 to 3 years old. So maybe we're in the infant stage, or maybe it's a kid with a GMFCS level 4 or 3 with CP, and maybe they're 2 years old, but they're still working on these kind of transitions leading to independent mobility. So your objectives are all going to follow together. So roll from back to stomach, roll from stomach to back, move forward on hands and knees. So it's short-term goals, but they're in sequence of how they're going to be accomplished, and it's all leading them to get independent mobility. Here's some examples of IEP goals. So again, in the school setting. So these are 1-year goals. So you will see in 1 year, Billy will follow the morning routines independently without verbal guidance 3 days in a row. Now, does that sound like a SMART goal to you in terms of PT goals that you've written? No. So this is an IEP goal, and remember the IEP goal is surrounding their academics and their functioning together. It's not a PT goal, it's something that the whole IEP team comes together to write. So it's not just PT related. But what part of it is PT related? Well, when you look at the morning routine, because they have to be able to do the morning routines independently without verbal guidance, you're talking about getting off of the bus, walking through the door, going up the steps, finding and opening your locker, hanging up your coat, entering your classroom, and sitting at your desk. All of those have aspects, depending on what the person has disability in, all of those PT can play a part in. So what other parties are probably going to be incorporated into this goal? The teacher, the classroom teacher. That's someone that would also be providing the verbal guidance throughout the day, the OT, and the PT. So those are probably the 3 most responsible parties to work towards this goal for 1 year. Let's look at another one. In 1 year, Jason will move from his homeroom to science class using his power wheelchair within the allotted 3 minutes before the bell rings at least 3 days each week. So typically you have about 3 minutes as you get older and you have to switch classrooms to get from one room to the other. Sometimes there's stairs involved. Sometimes they're on one side of the classroom, the school building, all the way to the other. So 3 minutes is a very short period of time if you have a disability. So Jason's goal is to be able to get from homeroom to science within the allotted 3 minutes using his wheelchair 3 days a week, his power wheelchair. So who is all going to play a part? The homeroom teacher, the science teacher, and the PT. So the PT is going to be teaching him how to use his power wheelchair. Homeroom and science teacher are going to be helping him navigate the beginning and the end of that as well. Another example. In 1 year and with adult supervision, Debbie will stand up from her wheelchair and use her walker to walk in line with her class to lunch 3 days in a row. So who all is going to be involved? Again, it's not just a PT goal. It's not written SMART. You don't use medical jargon. So it's written very parent friendly. And the PT and the OT would be involved, and the lunchroom supervisor. Third goal. In 1 year, Carolyn will play on 3 pieces of playground equipment during recess over a 2-day period. So who would be involved? A playground supervisor, PE teacher, and PT. So those are just ideas of who would be involved. It could be other people as well, but just to give you an idea of how comprehensive and how much of a team approach this is, and it's not just PT related. It is academic and functional mobility related. So I want to end this presentation with what are the outcomes due to the IDEA. So this act has made huge changes for kids with disabilities. The majority of children with disabilities are being educated in their neighborhood schools, in regular classrooms with their non-disabled peers. This is a huge change. So from the 1970s to now, this has changed drastically. Graduation rates from youth with disabilities increased by 14% in 13 years. So that's a huge change in 13 years. Post-school employment rates for youth served under IDEA are twice those of older adults with similar disabilities who did not have the benefit of IDEA. Post-school employment rates are twice those of adults that did not benefit from IDEA. That's a huge post-employment rate. The percentage of college freshmen reporting disabilities has more than tripled since 1978. So what this is saying is that there's more access to higher levels of education for people with disabilities. So these are really large outcomes, really large benefits. So just to recap, I forgot to put like a summary slide on here, but the main takeaways: really understand the parts to the IDEA. So knowing the early intervention, the school-aged, what kind of services you can qualify for, how you are classified as having a disability to be eligible for these services. So really understand those areas. So if I give you a situation, will you be able to tell me if they would qualify for early intervention, or would they qualify for school therapies? And again, I'm not going to try to fool you. It would be a pretty obvious situation. It wouldn't be one that's on the border, because sometimes it's really hard to determine. I definitely want you to know the difference between a 504 plan and an IEP plan, or part of the IDEA. So knowing that one's accommodations versus one's the services, knowing the difference between those. Understanding some of the goals that you might write for a school-based IEP, and the team members involved. Those would all be good areas to know moving forward too, as those are main points to take away, and who's involved in the IEP and the IFSPs. So if you have any other questions or need me to help you connect more dots, just let me know. Other than that, this is it. I know on our syllabus it says promotion of health and wellness. We are not going to be doing that. That's something that if you take the pediatric elective, we'll get into further. But at this point, we're not going to include it this semester in the pediatric class. So hope you have found it beneficial, and please email me with any questions.